Well, hello, good afternoon. Welcome to the show, Perspectives Live. We are very excited about our guest today. We have Dr. Deb Lonzer. She is a physician leadership coach. She's also assistant professor at the Cleveland Clinic Lerner College of Medicine, as well as a forensic consultant. Uh, Dr. Lonzer, glad to have you on the show today.
It's great to see you again. Thanks for having me.
Same here. Yeah, a couple of years ago, last time I was in Cleveland, we had a great interview then. I'm looking forward to our interview today.
Me too.
And of course, one of the things I learned about you is that you're an expert in helping physicians who are looking to move into the executive status. So I've got lots of questions regarding that on how those you can help them with those leadership skills and do career coaching to get them from the physician to the executive status. But there's lots of other things I want to talk about within patient care as well. Does that sound good?
Great.
Awesome. Well, the first thing I'd like to do, just so our viewers can get a little bit more acquainted with you, I'm a little bit more acquainted with your background. I'd love for you to share with the rest of our viewers. First of all, how did you get into healthcare and into medicine? What inspired you to want to get into this field?
Yeah, it's interesting. It was really the melding of art and science. So there were no physicians in my family or anything. I didn't really know what to expect, but I knew that I loved science and math. And as I thought about careers, there was medicine, there was working in a scientific laboratory, there was being an engineer, but building relationships and having people around me and goofing off with them and making them laugh, that was a big part of who I was. So the ability to build relationships and actually to have that relationship building make me a better doctor, those two things just came together nicely, and I decided that that was it for me.
Awesome. And you're also you specialize as a pediatrician, so you're obviously dealing um, with the pediatric population. What was it that drew you to that portion? Because you've got medicine in general, but what is it that drew you to treating the children?
It was a slightly non-linear pathway for me. So as I went through medical school, I loved everything. It was all exciting and new and marvelous. And so as I went through, I thought, well, I want to be a surgeon of some kind, maybe an orthopedic surgeon. But wait, I like OB, and gynecologists get to do surgery. So there's the perfect thing for me. So I'm going to be an OBGYN. And I interviewed at 10 places for residency programs in OBGYN. And at the last place, which was down in Tampa, Florida, I looked around and thought, holy cow, like I like OBGYN, but I want to take care of the baby after it's delivered, not the mom. So I think I might have made a boo boo here. So I was lucky enough, I was able to get in touch with a couple programs, and I switched to pediatrics, and the rest is history. I never looked back with any regret at all. It was the right move for me. It worked out very well.
It's awesome. So talk to me about when you entered into the practice, when you started practicing medicine, the differences, maybe you can discuss similarities, differences or similarities between how you started practicing as a physician versus how it is now. What changes have you seen?
Gosh, yeah, it's really different. So my first year, I tried private practice, and it wasn't the right fit for me. I missed teaching and stuff like that. In private practice, though, we had like sheets of paper, like an 8.5 by 11 sheet of paper, and it would be divided into three or four columns. And in that column, each patient note would be about this long. So it said, here for cough, looks great, exam is this, treated him with this, done, draw a line, room for the next note. So when the EMR came around, holy cow, I mean, it impacts boomers the most, and I'm the tail end of the boomers. And so when it came along, I dug my feet in, said, this is not going to work, nobody's going to want this. And then years later, I was selling people on why the EMR is a good idea. It's got its pluses and minuses, but the EMR is huge. Um, the reimbursement system, the word reimbursement kind of bugs me a little bit because you don't reimburse your plumber. You pay your plumber for their service, right? But we accept reimbursement from a third party as opposed to being paid for our services, which is a little weird. Back then, there were insurance companies were different. They didn't tell you what to do nearly as much, and if at all, except for big things. Patients were potentially more likely to either pay for everything or to have insurance that covered everything. Co-payments were kind of not a big thing back then. Um, the collaboration and the collegiality among physicians was huge. I came to Cleveland Clinic because, I mean, I just got to wander around the halls with these great minds, and we would just bump into each other, and I'd say, "Hey, what about this?" And they'd say, "Hey, what about that?" And I would think, "Wow, like I get to walk down the hall and chit chat with people who are changing the face of medicine." There's a lot less chit chatting, so the clinic is still very collaborative, but there's not so much time to bump into somebody and say, let's have a cup of coffee because you're up on the EMR, doing your typing instead, I guess. So patients also had different expectations. They weren't as savvy. I could say to them, this is what I think it is, and this is what I think you need to do. And they would say, if that's what you think, then that's what I'll do. And now we get more like wiki patients. So I've already looked up 10 possible diagnoses, and I think I know how you need to treat me, but why don't you give me your perspective, and then we can decide, where we fall on how we're going to move forward.
Do you think that that's a good thing or a not so good thing, or what's your take on that?
As far as patients being more savvy, it's a good and bad thing. So it's a really good thing for you to know more about your body, to know more about your disease processes. But as in everything, a little information can be dangerous. So if I have a particular ache or pain or symptom, it could be associated with 10,500 different possible diagnoses. But if you look online, you're going to get 7 of them, and you're going to think, okay, well, it's got to be one of those, and it tells me I should treat it with, this. Whereas when I see it, I'm looking at you in a pile of experience that I've had with thousands and thousands of patients who've looked similar and had similar symptoms. And I can say to you with much more confidence, I see you and I know you and I know people that look like you. Therefore, this is the most likely thing it is. You're not just a random symptom in my computer, which is one of the reasons I think AI is great, but it's also not the panacea people may think it is. We're not all created the same. We're all created very similarly. Our organs are kind of in the same place and stuff, but there are a lot of differences, and there are a lot of differences in the way our nervous system works. The way I experience a particular symptom can be very different from the way you experience it. So having a human with experience who can lay eyes on you and have a conversation with you is way better than anything like the internet. I lost you. I don't know if you can see me.
Yeah, I can see you. You're good. So you're not able to see me?
I'm gonna sign back in.
Okay, so folks watching, just hold on tight. She's going to sign right back in here. And this is, if you have any questions, feel free and type those in.
Hi.
We'll be looking for those questions as we go along. Welcome back.
Thanks.
Okay, so we were talking about how different the practice is. Some of the how the patients are coming in with more information than before, and the pluses and minuses from that. I kind of want to move on to another point that it's very interesting too. Is being as we've got this knowledge set, you've got this knowledge set as a physician. How do you think that benefits the organization if these physicians are in the decision-making process when implementing these things like the EMRs or how they're changed, all these changes that we're doing in medicine. How important is that physicians are in that conversation, and then how can physicians position themselves to be in those leadership roles so that they can be part of that decision making process. I'd love to talk about some of that with you as well.
Yeah, it's a really important point. So, if GM decides to build a new car and they ask the chef at the best restaurant in town what parts to use, maybe the car would taste good, but it's not going to be the best car they can make. So when someone who's not a physician tells me, here's your EMR, I put everything in it that you're going to need, but they didn't talk to me or one of my many colleagues before they put it together, then the likelihood is that some buttons are going to be stupid and some information is not going to go to the right place and it's going to be clunky. And I don't understand why physicians aren't on the front end of developing everything from insurance packages to EMRs to everything that we use. And so it is critical, I think, that we get
Ooh, I just lost you. We just lost her.
of
There we
experience.
go. You left and now you're back. Sorry, you said
Did you?
you were saying that we need that physicians should be on the front end on
Yeah.
a lot of these different things. So pick up with there from there, please.
Yeah, we need to use the experience that we have with the visions that we have and put together what we need now with the ability to change it as we see medicine changing. Because if we're on the front lines, then we can have some good guesses about where we should and could go. So, working at a place like Cleveland Clinic that is physician run gives us an opportunity to have an impact on what the clinic itself does and what equipment or rules or whatever we end up using or what projects we plan and that sort of stuff. And that's a really fun thing. Um, it also, because of the leverage that we have, we're a pretty big system with a fairly good reputation. So people listen to us, and if we say, hey, we have 500 physicians that think that this is a great idea, they'll say, oh, hey, let me see what you mean by that. So it's important then to have the best leaders at a place like that so that the people that are on the front lines are thinkers and innovators and are people that are trying to improve the practice of medicine for patients, for their colleagues, for themselves, for science in general. There are a lot of audience members essentially that we're trying to please as we try to make medicine better. And so I had the opportunity to go through the leadership ranks at the clinic, starting out as a general pediatrician and then ending up being able to build a department of 100 pediatricians and being on the board of governors and being vice chair of the Children's Hospital to develop our strategic planning and our outpatient operations. And so my experience came in very handy, and I was humbled every day I walked into the facility and thought, geez, the things that I'm doing are changing the way we function, and I think we're getting better. And so the more voices we can get that are in there saying these are the things we need to change, the better off we are. And that's around diversity. It's around people practicing in different communities because the clinic is based in Cleveland, but we have tons of suburban practices and urban practices and some rural practices. And so we can consider lots of different populations of people and of diseases as we, try to innovate the future of medicine. So the more the merrier when it comes to leadership. We need to get away from thinking there need to be like, three people at the top and everybody else in the middle. It needs to be a lot of people that are rising to the top and making decisions that help all of us.
So, what are some things that a physician who wants to move into leadership, what are some things they should be thinking about or doing? Obviously, this is part of what you do as a coach. What are some things that you would suggest they look at uh, doing or implementing in order to put themselves in a better position to take advantage of those future roles in executive leadership?
Exposure is critical. So I could be the most visionary, decisive, risk taking, successful leader on the planet. But if only four people work in the area that I work in and nobody else knows what I'm doing, then I'm going to end up just working with those four people. So you need to find a way to get yourself in front of the people who make the decisions that can impact you. And sometimes that's in subtle ways, in the cafeteria or at a happy hour or at a CME meeting or grand rounds or lots of places that we end up being in the same room. Oftentimes we'll run in, listen to what we're there to listen to, and then we'll run out. But if you're looking to develop your leadership pathway, then it's important to go in, kind of pick out some people that are worth knowing, and then go up to them afterwards and say, "Hey, I thought this was really interesting. What did you think about that?" When I was trying to develop my leadership at Cleveland Clinic, Toby Cosgrove was the CEO. And every time I saw him in a room when I was a general pediatrician and not much more than that, I would walk up to him and I would say, "Hey, Dr. Cosgrove, it's Deb Lonzer. I think we met at blah, blah, blah." And then I would have a conversation with him. And he was very collegial and very open to those conversations. And the next thing you knew, as I got to talk to other people about roles that I wanted, I could say, when I was talking to Dr. Cosgrove the other day, and so name dropping, actually getting to know people, getting as many people that you respect to rub off on you, and then make introductions for you. I had a couple of really good mentors who were not necessarily all about leadership, but they had been around a while. They had great institutional memory, and they behind the scenes, and that was enormously helpful for me.
Absolutely. So, in terms of qualities or characteristics, if you could just name just a couple of them. Ooh, it's like we lost it again. Well, we apologize for this, folks. We got little issues with the internet. Little early
I'm
there this
not sure
afternoon.
what's happening.
So what I was,
I don't.
that's okay. Yeah, sometimes with the internet it fluctuates. So the question I was asking was, what do you think are some common characteristics? Now we know that physicians can practice medicine if they're practicing at this time, but what are some common characteristics that it would take to become good leaders? Like, if you could name some of those common things that will help them to know that, okay, they may be a good fit for an executive position. Maybe you can kind of go over some of those things.
Here's where women and men can sometimes diverge. So, for women in particular, communication is really important to us, and so being able to communicate in a way that expresses some gravitas and some importance and gets your value out there is really important for women, because we can sometimes sit back and say, well, somebody else is going to say something similar, so I'll just wait until they do. And collaboration and collegiality is important to us, but we need to do it in a way that that gives us a little bit of an edge. So when you walk up to someone at a meeting, walk up with a purpose. Walk up and say, "I was watching this the other day, and this is what I think may be important for us to know. What do you think?" So get your opinion out there first, and then ask them to feed back to you, because everybody wants to get their opinion out there, right? They want to know that you respect them, but you need to get yours out first so they can see, okay, that person's on the ball. This is worth my time to have this conversation. And those little conversations can go such a long way. You can have 20 people that you've spoken to just for 5 or 10 minutes along the way. But if those 20 people all happen to be leaders and sit in circles that are important, your name's going to come up, and suddenly you're going to be thought of as a potential for the next leadership position. So, get out there, get your opinions out there, make sure your opinions are educated. So do some reading. Nobody wants to listen to somebody say, "This is what I think," unless you have some science to back it up. We're all scientists deep down under, right? So the more information you can feed people and then ask for their opinion, and the more people you can get in front of, it's really important. Sitting in meetings is
Yeah.
really important too. So, we got the lean in perspective, and I don't disagree with that. But what happens to women who are trying to lean in sometimes is that they kind of lean in a little bit, and so I'm a woman. I'm sitting at the table with a group of important executive men, and they're talking about something, and as a woman, I think, wow, well, they have so much more experience. They probably know better, so maybe I won't say this out loud. And then someone else says it, and I just want to snap because I know I should have said it first. So if you have an idea that sounds interesting and good to you, get it out there and get some feedback on it. If it's a dumb idea, at least no ideas are totally dumb, right? At least you got the idea that you're listening, you're paying attention, you're thinking, you're trying to innovate. It's out there. So that's important. And oftentimes women will find themselves at a table, and I'll say, hey, I really think we should try this project, and it won't get any traction, but 10 minutes later the guy next to me will say, hey, I really think we should try this project, and someone says, that's a great idea, because here's this important person that everyone knows who's saying what I just said. So the way I attack that is I listen to him and I nod my head in approval. I'll lean into the conversation, and then I'll say, I am so happy that you agree with me about this, because earlier when I brought it up, what I meant was, and then I'll add a little extra onto it. So I'm not stepping on anyone's toes. I'm thanking them for agreeing with me, but I'm making it known that I have something to offer too, and that I said it first. It's not a competition, but it is important to let people know that you're a thinker.
Yeah, absolutely. And also as the point you made earlier about having a meaningful conversation where you're bringing something to the table first, and you're having that discussion, I can see how when that next meeting comes up and they're considering certain people, and your name comes up, that executive who you talk to is going to remember that conversation. They're more likely to remember you versus just a name on a list. Would you agree with that?
Absolutely. Face time is so important.
Yeah, it makes sense. So let's talk about some issues that are common to medicine across the board, and perhaps if physicians, as they find themselves in these leadership positions, these are some things they'll be talking about. Burnout is a really big issue right now, and that's something that you mentioned to me earlier, and how even the suicide rate has even gone up amongst physicians and other healthcare providers. So maybe we can speak to what are some things that you have seen or observed that we can use, tools, strategies that can help to tackle and bring down those numbers to a more workable level in terms of the burnout.
Yeah, it's scary because 1 in 5 physicians is depressed or has been in the last year, and of those people, a quarter of them think about suicide, and 400 of them actually do it every year. So these are big numbers. These are scary numbers. The satisfaction rate for
Mm.
the professionals,
You're
I'm,
back.
I'm really sorry about that. But
That's
the
okay. So you,
professional
you left off.
satisfaction
You left off at satisfaction rate. So go ahead and continue from there.
the professional satisfaction rate of professionals tends to sit around 85%, business, law, whatever. In medicine, it's just below. We're outliers, significant outliers, and half of women are burned out, a third of men are burned out, and there were some interesting studies that looked at it generationally, and I think I mentioned earlier that boomers are dying with the EMR, but Gen X is experiencing a ton of burnout because they're that sandwich generation now, right? So they're building their career, they're trying to develop leadership and practices and whatever, and they've got their family that they live with and their family that they care for that's older than them, and so those guys are experiencing a lot of burnout. And um, as as we look at what the biggest factors are. So number one is paperwork across the board, every age group, every specialty. It's paperwork. We just spend so much time with paper rather than with patients, and some of that is important. Record keeping is better, and we send out more communications, but we also have to apply for so many different things for patients and fight with insurance companies, and all of that is paperwork. And then we want to get paid, so we have to do the value-based reimbursement stuff, and some of that actually provides value, and some of it has no value whatsoever except to people that cut down trees. And so paperwork can really just eat you alive. And then, you asked what was different now as opposed to when I started. Respect from colleagues and people that we work with who are not physicians has decreased. Respect from the public has decreased. Autonomy is dwindling so fast, it's hard to even remember what it was like when we actually ran our own careers. So those are some big bits about why we're feeling burnout. And it's not that medicine doesn't recognize it. Hospitals and healthcare organizations, they see it. They know it's a crisis, and they're trying to approach it. But they're trying to approach it in ways that are used for other problems that we have. So we have committees and we have wellness programs, and the hardest thing about those, the reason that two-thirds of physicians don't ever avail themselves of these wellness programs, is that it takes time. So you want me to now block my schedule, see fewer patients so I don't get credit for RVUs, and have less time to chart, so I have another hour of charting to do at home, and go sit in a room where wellness will be discussed in a way that may or may not speak to me. And so I think it's more important for us to move forward with empowering physicians. We're not dumb. We understand psychology and emotions and all of that stuff personally. And so we should be able to come up with things that work for us. And so it's that balance of figuring out how do we empower the people who really need the programs as opposed to prescribing a program for someone who's already inundated with no autonomy and no time.
That makes sense. That brings me to another thing that I know also plays in this to burnout would be the staffing issues. What do you think is important for hospitals to look at from a staffing perspective? Like, for instance, even something as simple as a scribe to help with inputting information in the EMR. What are some things that perhaps hospitals can do to help alleviate the burnout issue by improving the staffing? Do you see any areas for improvement there?
I do. Um, when we first started out, we had a physician, we had a nurse, we had a secretary, and that triad pretty much ran everything when you were looking at outpatient practice. And then over time, as we primarily became systems, so only 15% of physicians practice in a solo practice anymore. So as we became part of these systems and hospitals, we started sharing resources, which is great. That should actually be good for the bottom line for everyone. But as we share the resources, they become less specifically knowledgeable about each individual practice. So there's a higher learning curve, and it takes longer for those people to do for me what someone who was sitting right next to me would be able to do. Um,
Yeah.
uh, the staffing, we worried about physicians. You have to have the physicians, and you have to have the providers. You have to have nurse practitioners for certain practices, and making efficiencies and taking care of large numbers of patients as well. But then, as the systems got bigger, we started thinking, well, we should run this like a business because these are big budgets, right? We need people who understand business. So I feel like we got kind of top heavy on administrative folks. And so instead of having just some little administrators that take care of our practice. We now have big administrators who do multiple practices, multiple departments, multiple institutes, multiple whatever. And there are lots of them who then are looking at big groups of physicians who may or may not be similar in many ways. And then they're prescribing things that we should do because they understand the bottom line and they understand the business of medicine, but they don't so much understand the medicine of medicine. And what feels to me like it got lost along this way is the personal relationship between physician and support staff. So, me having a medical assistant who just checks patients in, great, scribes for me, better. A nurse who takes my phone calls from patients and does not throw up a wall, but invites in the people that need to come in so they don't make 10 more phone calls or go to the emergency room. That nurse who's knowledgeable and understands my practice, very important. And front desk people, I mean, the paperwork is not just us. It's our MAs, it's our secretaries, it's our the people that answer our phones. We need, I think, more of those people who are frontline who can support us in ways that these are not tremendously expensive positions. You know, we could have many more of them rather than thinking about how we're going to pay for a high paid administrative, you know, chief executive something. We could get 10 medical assistants or PSRs who answer our phones, and they could make us so efficient that we wouldn't need the business people to tell us how to be more efficient because we could do it on the front lines where we understand what's happening.
Got it. Okay. Let's talk a little bit about technology. We talked a little bit about it before with the AI, that AI is certainly not a panacea for everything. But what are some ways that technology can actually add to the practice and make it better?
I think telemedicine and virtual medicine is amazing and has lots of opportunities to help us, provided that we fit it into our practice in the right way. So we used to tell patients they had to come see us, and we were only going to be in the hospitals. And then we said, okay, well, we're going to come closer to your house, but we're going to be in this brick and mortar place. And then we said, well, you know, maybe you don't actually need to leave your house. Maybe you could talk to me on the phone with a video like we're doing, and I could get a ton of information from you and I could care for you better without dragging you out of your house. So we have lots of ways that we can care for people. And using the technology of virtual visits, it, you know, just like the Gen Xers who are appreciative of an EMR, younger people. So, you know, I'm a pediatrician. I'm looking at generally young couples, young moms. They're savvy about things that are electronic. They want to be able to pick up their phone from their car in the parking lot and say, "Hey, this is what's going on with me. Can you help me? You know, it's my lunch break, and then I'm going to go back to work or whatever." So I think that technology is critical, and we probably have ways to offer it that we're not quite doing yet. I think that we're still focused on the way medicine used to be, and it feels like spending our time looking at someone on a camera is not the best use of our time when we could be doing other things. But we can get lots of patients through in a way that satisfies them and treats them appropriately as long as we follow the appropriate guidelines and practice medicine like we would in the office. Not everything gets an antibiotic. A patient can ask for something and we have to say, no, that's not really right for this. We can do that online as well as we can do it in person.
Mm.
And for physicians, you know, the remote stuff is amazing. I can know your blood sugar throughout the day, whenever I want to know it. I can get your blood pressure. I can get your heart rate. I can be in an emergency department in rural Montana, and I can have a camera in the patient exam room, and someone in Cleveland can be helping me with that patient because I don't have a pediatrician out in the middle of nowhere. So someone else can bring their expertise remotely into my emergency department or into my ICU. Again, rural areas, hospitals are closing down like crazy, and it's unfortunate because people need health care everywhere, even in rural areas, of course. And so relying on the remote technology can be critical for them. You don't have to have a radiologist on site anymore. You can have all of your radiology read by someone who's in a time zone that's awake whenever you need it. So 24-hour a day readings on radiology. And I mean, the stuff is amazing. And if we sit back and actually think about the potential benefits and the specialties where those benefits can help, and the populations of patients, of people who need that kind of care, we can put together some really creative packages and take care of everybody while keeping physicians happy and everybody's practicing top of license. It's kind of amazing.
Yeah, I want to ask a question from a talent acquisition standpoint, since a lot of the viewers who watch this are in that field. So, for organizations to be attractive to a physician, to try and recruit physicians, particularly if they're not from the same area, like maybe it's some other place nationwide, what are some things that those hospitals should be talking about in terms of what they have to offer? What's appealing to a physician? What is a physician wanting to hear these days that's relevant to them? I'd love to get your opinion, your thoughts on that.
Sure. And I think that sometimes physicians and the people trying to hire us are not thinking exactly alike. So, going back to the whole burnout thing, physicians are willing to take a $10,000 to $50,000 salary cut, depending on their age and their experience, just to get some more life balance. So throwing extra cash at me might not necessarily lead me to go live in rural Montana again. I love Montana, so I'm not picking on them. But if you say to me, your life balance is better, and I think that I know it's a minor thing, but life balance to me is way more important than work life balance. If you're a physician, you don't have work and life. You have life, and work is part of it, and you do it a lot for long hours. And so life balance is important. That means that I should be able to spend time seeing patients, spend time reading so I am the best physician I can be, spend time collaborating with colleagues, have a little bit of autonomy about how I use my day. So instead of saying you have to start at 7, end at 5, you have to see 27 patients every Monday, say to me, this is my expectation for you for per month. You can decide where it's best for you to put your hours in. Come in every Saturday and Sunday and don't work on Monday. There are lots of ways that we can arrange our hours using what we know about when patients want to see us and when we're most available. So that little bit of autonomy, a little bit of time to do the reading and get the most up-to-date science. And a nice, it's got to be a nice reimbursement package, but that's not what drives physicians. There are a lot more important things than that.
That's a good point. So, obviously, that we pay, we want it to be competitive to a point, but it doesn't necessarily have to be the top. It could be somewhere in the
Exactly.
mid level if they can offer that life balance you're talking about.
Exactly. I think that, especially with upcoming generations, they're not as willing as our parents were to just say, well, that's the way it is. I have to be at work from 5:30 a.m. until 7 p.m. and there's nothing I can do about it. They're going to say, wait a second, I want to live my life too. I want to have friends and a family and hobbies and eat out and all of the things that are important to me. And so if you say to me, we're not going to be able to match that salary. We're going to come in at $10,000 less, but here's what we can give you, and that's autonomy and time. Oh my gosh, I mean that's priceless for people.
Yeah, like I read recently, you know, uh, money is something you can always earn back, but you can't get time back, which
That
makes
that
time
is
much more valuable.
everybody should have that little bumper sticker on their car, so when they get up in the morning and get in their car, they see it because it's true. I mean, time, we feel like we're going to be able to go back and get rid of regrets or do things differently. And then suddenly you think, huh, I'm never going to be that age again. I don't have that opportunity anymore. So we need to take full advantage of our personal and professional lives and all of our relationships, work and otherwise, as we're going through our days, because then you end up happier and more well-rounded and more energetic and able to give yourself more fully while you're at work. We need our downtime, we need our sleep, we need our time with people who reinvigorate us.
You know, with all the things that you do, um, practice as a pediatrician, physician, executive leadership coach, the forensic science that you do, forensic consulting. There has to be some level of time, and you also have family. Must be some measure of time management. What is your secret? Can you share anything about what you're able to do to balance all of that?
Um, So I'm a very decisive person who's very good at prioritizing. So those are two pretty broad umbrellas, I guess, but they're critical. And so I look at my calendar at the beginning of the week and I say, okay, so these are the things I have got to get done this week. And then I chunk them out across the days. Maybe one day is going to be my forensic day, or maybe when I see exactly what has to get done over the course of that week, then I can figure out where to plug things in. I do a lot of work from home now. I can't practice medicine right now clinically because I'm on disability. I have some health issues that don't allow me to do all of the things I used to do with patients. So that's a blessing and a curse, because now I work primarily from home, which is great, but it's also like, well, I could watch a cooking show or I could go and look at those records. So there's a whole different prioritization that comes into play. And I would die without a calendar. I have a notebook that I carry in my briefcase that I write little things that have to get done. I also have a phone that has to-do lists. I merge them together every night. And in the morning, I look at what I'm supposed to get done that day. And I make sure that I have my iCalendar or my Outlook calendar filled in with all of the spots taken, so I know when I'm going to do what, so I don't have to think about it. We spend a lot of time thinking about things that are not critical to think about. I shouldn't have to think about what I'm going to do first. It's important to get the ugliest thing of the day done first, because then you can say, wow, I just scaled that mountain. I ate that frog. I'm ready to go for anything now. So put that first. That's what I'll throw in my calendar at 8 a.m. And then after that, I'll have more fun stuff that I can, if I get done 20 minutes early, then I can go walk a dog or whatever. But my start times stay set, even if the end times finish a little bit early.
That's a good point. And when you said "eat the frog," you reminded me of a book by Brian Tracy. He has a book called "Eat the Frog," but the whole premise of the
Yeah,
book is you do the most unpleasant thing that you don't want to do first. That way, everything else is easy.
right. It all seems
Yeah,
less
so that's
unpalatable once you do that.
exactly. Okay, so we're going to wrap up, but before we wrap up, I have just a couple of rapid fire questions to ask. These are preferences. I want to get your preferences on things. I'm going to go through a
Okay.
handful of them, and I want you to just give me the first thing that crosses your mind as far as your
Uh,
preference. Okay. Okay. So we
okay.
call it this or that. All right. So the first one is watch a video or read an article.
Read an article.
Instagram or Facebook.
Facebook.
LinkedIn or Twitter.
LinkedIn.
Call or text.
Text. Never thought I'd say that.
Okay. um, email or iMessage.
Email.
Okay. Phone or a tablet.
I use both for different things. I have my phone with me more, so we'll go phone.
Okay. Netflix or Amazon Prime.
Netflix.
Movie theater or stream.
I I stream way more, but I have to see the big movies in a theater.
Got it. Okay. Um, Indeed or Glassdoor?
Huh. I'm gonna take a hard pass on that one.
Okay, all
I don't
right.
know.
Uh,
I don't know Glassdoor.
okay, all right. So driving or self-driving cars?
Oh, driving. I love driving.
Okay, renting a car or doing like a Uber Lyft?
Renting a car.
Okay. You prefer to drive or fly?
I prefer to fly, except it's so inconvenient that it's easier to drive. So, I drive more than I used to now.
Yeah. How about TV shows or movies?
Um, TV shows.
Okay, this is a hard one here. Instagram or TikTok?
Yeah, Instagram.
Okay,
I'm
and
old, I guess,
Coke
right?
or
My daughter says nobody uses Instagram anymore.
how old's your daughter?
She's 15.
Okay, so yeah, that's about right. That's about right. That's the hottest thing right now is the TikTok with it
Yeah.
with that age. Coca-Cola or Pepsi?
Neither but Coke.
Okay, YouTube or cable TV?
Cable TV.
Thank you for playing. Thank you so much.
Yeah,
Thank
absolutely.
now
That was fun.
our viewers, if they want to, interact with you more, especially if they're interested in your coaching, your physician leadership coaching, would you suggest they go to your website? We can make sure we leave that in the outro in the end.
Yeah, absolutely. My website is careertriagemd.com, and they can look and see the way I kind of put together my offerings. And anybody can reach out to me by email, through LinkedIn, whatever. I'm really open to getting a message and just saying maybe I can help you, maybe I can't, or whatever.
Great. So, guys, you've heard it. If you looking at this on LinkedIn, feel free to reach out to her there. Well, Dr. Lanzer, I definitely want to thank you for having you on the show. Really appreciate your time today, and we look forward to having you back on the show.
Thank you so much. It's always such a pleasure to talk to you. So I really had fun today. It flew by. You're really good at this. Thank you.
Oh, wow. Thank you. Yes, the time did fly by. All right. Thank you so much for your time, Dr. Lanzer. Have a good one.